Welcome. Thank you for joining us today. As she said, I'm Dr. Korenblit. I'm a practicing gastroenterologist, about 11 years of experience, located in sunny Florida. That's where I'm coming to you from. We are going to be kind of delving into a little bit with exocrine pancreas insufficiency today. Although, as she mentioned, if there are any burning questions at all, GI related or otherwise, when we get to the Q&A, feel free to ask. Common topics, not common topics, whatever you guys need. This was just going to focus a little bit on EPI as well as associated conditions that mimic that. So today, we're going to do a little bit of a deep dive, talk a little bit about how the pancreas functions in normal digestion, how it relates, and maybe some tips on how to relate this kind of information to patients as they come up with asking. And then we'll talk a little about how EPI works, what it is, how it is as a clinical entity, and diagnostic approaches that you might have, as well as some therapeutic options that are available, since there are some very good options. And then we have a couple of patient cases that we're going to bring in to try to tie this all together. So the pancreas is it's a critical organ. I used to tell patients it's my favorite organ because I am I'm not exactly a pancreatologist, but I am an advanced endoscopist. I do a lot of stuff with the pancreas and have spent a lot of time training on that. Most people, the layperson is like, I've heard of a pancreas. I don't know what it is. Our pancreas is a critical endocrine and exocrine organ. So even though the endocrine stuff belongs to our friends and endocrinologists, I take ownership of the rest of the pancreas because really the majority of it is the exocrine function. Endocrine pancreas, most of us are familiar with. These are the islets of Langerhans, which are scattered throughout the pancreas. These are the hormone-producing cells. They produce insulin, glucagon, somatostatin, pancreatic polypeptide, even some ghrelin and things like that. These are what are implicated in diabetes, in other endocrine disorders, and they're dispersed throughout the pancreas and really are the powerhouse of blood sugar regulation, hormonal regulation, as far as even digestion goes, because they're sensing a lot of that. The blood flow of the endocrine and exocrine pancreas is basically intertwined. So problems with one are going to cause problems with the other, and vice versa. And that's why a lot of times we see associated conditions like EPI with diabetes and different pancreatic pathology. The exocrine pancreas, which we might not be quite as familiar with, these are acinar cells. So basically, I tell patients and folks to think about it like acinar cells being a house on a cul-de-sac. They will synthesize, store, and then eventually secrete pancreatic enzymes, which will help kind of break down fats, proteins, and carbohydrates to a lesser extent. These are lipase, protease, amylase, as well as elastase. All of this stuff is packaged in these cells as proenzymes. You don't want this stuff activating inside the pancreas. That's how you get pancreatitis when the duct is blocked for various reasons, and these enzymes activate and spill out. So I tell people, think of them as house on a cul-de-sac, and then the enzymes are cars that are going to go out the driveways, and then they're going to go down first the small streets, then the larger streets, and finally down the highway to the duodenum, the main pancreatic duct. Because these are proenzymes, they're not active. They're kind of in a pre-activation state. They need to be activated, and one of the ways that is the ductal cells will then secrete sodium bicarbonate to aid them to come down. And when all that stuff hits the duodenum at once with the food, you get neutralization of the acids. The enzymes activate. They start munching down on all those nutrients and start breaking them apart. So that's really kind of how the pancreas fits into the digestion in a nutshell. Excuse me. Normal digestion really breaks down to breaking down our carbohydrates, proteins, and fats, which are our main nutrient sources. Carbohydrates and proteins have some alternate pathways as opposed to the pancreas. Carbohydrates really start as either disaccharides and a lot of stuff we eat, table sugar, things like that, and polysaccharides, your starches and things like that. Digestion really begins in the mouth. Salivary glands produce amylase. That's why amylase is a terrible test for acute pancreatitis. It's produced all over the body. If you vomit, you'll increase your amylase in your blood. So this stuff starts to digest. The stomach will then grind up the food, and then the small bowel produces more amylase, and eventually you chop everything up into disaccharides, and that the pancreatic amylase does play a role in this. Then you have the final brush border breakdown of disaccharides into monosaccharides. That's what has to be absorbed. Disaccharidase deficiency is something we also deal with that can mimic IBD, the most common IBS, which is the most common being lactose intolerance. That's a deficiency in lactase, but we do have people with sucrase and isomaltase deficiency that we kind of sometimes recognize even as adults. It's not exactly a congenital thing. Once those are absorbed, they stop floating around and they make it to the bloodstream. So protein, same kind of thing. Digestion really begins in the stomach. You have pepsin, pepsinogen, which then converts the pepsin in stomach acid, mixes the protein, starts denaturing them. Stomach grinds up the food, and then the pancreatic enzymes go to work and allow them to be absorbed throughout the small bowel. So fat, which is what we kind of are focusing on today, as far as exocrine pancreas insufficiency, is our most energy-rich nutrient. If you recall, 9 calories per gram versus 4 for proteins and carbohydrates. Fat digestion is really basically based on the pancreas, and to a lesser extent bile from the gallbladder and liver. Fat digestion, there's minimal amounts of gastric lipase. About 10% of our lipase function comes from the stomach. It gets ground up, all those enzymes start meeting, and then when it hits the duodenum, you have a combination of hormone signaling with secretin to send to the pancreas to send everything down, send those pancreatic enzymes, let the bicarbonate mix, and then everything gets all mixed together as the fats are broken down. And that's when bile acids and bile micelles start causing, bile salts start kind of creating little packets, micelles, if you will, that'll then get absorbed throughout the jejunum, lesser extent the ileum, and then ultimately are absorbed. And this is kind of the crux of where exocrine pancreas insufficiency gets most of its symptoms from. If you're not breaking down fats, that stuff is floating through the digestive tract. It's hitting the colon. Nothing is absorbed in the colon except water. The colon is basically a little bit of a trash heap. It's designed to kind of store stool and suck out water. And when that fat hits that, it's basically going to generate diarrhea, and all those nutrients are going to be lost to the patient. So what is EPI? Well, EPI is a kind of a general term for inadequate production, delivery, or activity of pancreatic enzymes needed for normal digestion. We'll talk about some of the associated conditions that go with this and why they're a problem, whether it's the production, delivery, or activity. A normal pancreas will secrete about 500,000 to 1 million lipase units per meal. Arbitrary unit. Kind of comes from the medications that we use, but when you measure what's going on in the small bowel, depending on the size of the patient, the fat content in the meal, how much secretin is made, and how healthy the pancreas is, that's the amount that you are normally secreting. When this doesn't happen, we get a lot of symptoms: diarrhea, abdominal pain, bloating, flatulence, which is all as a result of that fat malabsorption hitting the colon. Unexplained weight loss because you're losing your nutrient absorption, and ultimately deficiency in fat-soluble vitamins A, D, E, and K because you're not absorbing those vitamins along with the fat in the same manner, and those tend to go down. And then finally, steatorrhea. Steatorrhea is what we refer to as floating, greasy, fat-filled stools. This is a very late presentation. Everyone knows to ask about steatorrhea because it's something that perks, your training. But ultimately, most patients don't get steatorrhea until they've lost 90% or more of their pancreatic function. So it's a late, if somebody clues me into that, I know we are going to have to focus on this. But the other symptoms, the diarrhea, the abdominal pain, they all kind of are much earlier signs and perhaps should clue you in that this should at least be part of your differential. And, those symptoms are really due to that fat and nutrient malabsorption. So this is kind of a pretty key slide. So there is a lot of overlap with other GI syndromes. This is not an easy clinical entity to kind of tease out. If you look under EPI, we've got diarrhea, abdominal pain, bloating, flatulence, unexpected weight loss, and steatorrhea. But you look at IBSD, you've got the same thing: diarrhea, abdominal pain, bloating, and flatulence. I have had patients lose weight. I've had patients have steatorrhea, or at least report what they think is steatorrhea. SIBO, absolutely an overlap. Small intestinal bacterial overgrowth, which is a very hot entity on the internet. If you ask most of your patients, this is an imbalance or perhaps overgrowth of bacteria in the small bowel, a place that's very difficult to tease out exactly what bacteria is supposed to be in there. Hard to test for. We do various breath tests. Sometimes we send for specialized stool tests, things like that, but these aren't the most accurate things in the world. And you can see the symptoms basically overlap. So that's definitely something that I think about on the same differential. So then we've got IBD, ulcerative colitis, and Crohn's. Ulcerative colitis can certainly present with diarrhea, abdominal pain, sometimes weight loss, usually bloody diarrhea, but not always. I've had a select few patients who present purely with diarrhea, and then we go in, we scope them, and sure enough, they have ulcerative colitis. Crohn's in a similar manner, and those patients actually not only can develop steatorrhea, they actually can develop EPI, particularly children. There is a growing association between exocrine pancreas insufficiency and IBD, particularly in children. And interestingly, when you treat the Crohn's disease, they tend to get better. And that's not always true in adults, but in kids, they become so malnourished that once you treat their Crohn's, they perk up, they start losing that EPI. Their pancreas is simply not keeping up with their needs. With UC, it's a little bit less known. And some of this has to do with hormone signaling. We're not 100% sure why these entities. And then finally, celiac disease. Celiac disease, very much a mimic of EPI because it is essentially a loss in of function and kind of integrity of that brush border in the small bowel. So you by very nature malabsorb nutrients. Patients will get the same kinds of symptoms: diarrhea, bloating, abdominal pain. They'll certainly lose weight. I generally, if I am working up a patient who has these symptoms for IBSD, for EPI, celiac, things like that, I will kind of a little bit shotgun approach with the blood work and for celiac with some of the stool testing for EPI. We'll talk a little bit about their symptoms, food diaries, things like that, because really, the facts present, and this is mostly from surveys and things like that, but 1 in 4 patients who were ultimately diagnosed with EPI were first told that they had something else. They were told they had IBSD, they were told they had SIBO, things like that. And the average patient will receive 4 to 6 diagnostic tests, CT scans, lab testing, stool testing, and endoscopy and colonoscopy prior to them having their EPI diagnosis sealed, and then they'll wait about 4 years on average for that diagnosis to be made. And then, as I said, steatorrhea is a very late presenting sign of decreased pancreatic output. So really, you can have subclinical signs of EPI because patients will sometimes realize, oh man, I feel really bad after I eat McDonald's, after I eat a cheeseburger. So they start limiting their fat intake, and that will further kind of punt the ball a little bit on the diagnosis because now they're just not using their pancreas as much. Their symptoms are a little bit better and they're feeling better, which is great, but they'll eventually kind of need that pancreatic support. So just kind of keep in mind the take-home message is EPI might not be the solution, but it certainly is something that needs to be in your differential diagnosis. And how are we going to make that diagnosis? Well, it's largely a clinical diagnosis. Unfortunately, you can suspect it when you have 1 or more symptoms as well as an associated condition. But I will tell you, even though we have some very clear-cut associated conditions, the majority of patients actually are idiopathic. Particularly young folks. I've run into some people who are in their 20s and 30s who have been diagnosed with EPI. We don't really know why. Their clinical course is sometimes variable. They get better, they get worse. They do their pancreatic enzyme replacement, and sometimes they spontaneously recover. Patients with other associated conditions, which we'll talk about, like chronic pancreatitis and pancreatic surgery, they're unfortunately not going to get better. And the signs and symptoms are not always evident. They'll voluntarily limit fat, which is a big part of this. Patients are also embarrassed or reluctant to discuss. The paradigm I talk about is the older gentleman, maybe a bit of a smoker, maybe a bit of a drinker. His pancreas is kind of worn out a little bit, and he's dragged in by his wife because she's tired of hearing about his problems, but he's reluctant to discuss it because he doesn't want to go to the doctor. And this kind of happens. This isn't exactly an easy thing to talk about. Your diarrhea, your stool habits, some patients are super comfortable with it. Other patients are not. And then their dietary history is also kind of complicated by recall bias. I couldn't even tell you what I had for lunch yesterday, to be honest. And most patients think that they're eating what they're eating, but they're really not, and they don't remember everything. And once again, they're self-limiting that fat, and they're not quite understanding. And then that EPI can be transient in those idiopathic cases or a very late presenting sign, as we talk about some of the diabetics and chronic pancreatitis, things like that. So testing is available, and we'll talk about what the specifics of that are. Imaging, certainly to look for associated conditions. If you don't have a super obvious history, like the patient had a Whipple procedure and is missing part of their pancreas. Fecal elastase is going to be the mainstay of our therapy. Fecal elastase, as we'll talk about, is an enzyme present in the stool that can be measured and is a surrogate for pancreatic function. It is not in any of our treatments of pancreatic enzyme replacement, so you can even follow it while the patient is on treatment, and it is an enzyme that, for whatever reason, it survives, passes through the digestive tract. It can be quantified in the stool relatively easily. The more modern tests that have been out in the last 10 years or so are actually fantastic. When I was a fellow and a med student, they told us, oh, elastase, well, that's a coin flip, whether that's even going to tell you what's going on with the patient. Well, now it's really much more accurate. Fecal fat collection, specifically a 24-hour fecal fat, is a nice test when it's can be done accurately by the patient. It really does a nice job, but it's hard to convince someone to do a 24-hour fat collection. Actually, even eat, you really need to eat a standardized diet. In all the clinical trials of all these different medicines, the patients are put on an 80-gram or 100-gram fat diet. So you really want to be on a standardized diet. You got to collect all the stool. It's gross. And doing a spot fecal fat is unfortunately just not that helpful. Most of the time it says, yes, there is some fat in the stool, and then I don't know what to do with that information. And then a secretin stimulation test. If you wanted to get one of these, it's challenging. It is done a lot in children where you give secretin or sometimes cholecystokinin, which can fill in through the IV, and you literally put an endoscope down in the duodenum and you stare at the opening of the ampulla and you suck out the pancreas juice at various time periods, and then you send it to a lab. This is actually requires specialized lab testing. That's why where I live, it's at the Children's Hospital only, because the peds guys love doing this thing. I've never successfully done it in an adult, but it is an option that exists. So what are those associated conditions? Well, like I said, idiopathic is obviously a big part of it, but really we think about these common and not so common associated conditions. So chronic pancreatitis is the first and foremost. Chronic pancreatitis is the chronic, obviously, destruction of the pancreas for various reasons, whether that's from heavy alcohol use, smoking contributing, autoimmune causes, and even genetic causes. And sometimes it's a kind of a combination of all of those. People who have a true genetic chronic pancreatitis, like a SPINK1 gene mutation or PRSS1 gene mutation, they get chronic pancreatitis in their teens and 20s. What I'm more talking about is kind of, you have the older gentleman usually, or sometimes lady, they've drank a little bit, they smoked a little bit, their pancreas they're in their 70s, their pancreas is a little bit worn out, and they don't have full-blown chronic pancreatitis with calcifications, but they just have an atrophic, sometimes fat-filled pancreas that's just not doing its job. And this is really kind of a form of chronic pancreatitis. And severe chronic pancreatitis does have some endoscopic treatments. We can tease those out later if anyone is interested. And that's one of the reasons why we do imaging on these patients, because we want to make sure there's nothing we can intervene on. But chronic pancreatitis is really what you think about classically with EPI. Cystic fibrosis, also an absolute classic thing. Once again, not super common in my adult population. I actually do share a cystic fibrosis kind of program with a local pulmonologist. So we do get these patients. We have to screen them for pancreatic cancer, things like that. But that's a classic thing. Cystic fibrosis patients need to be placed on pancreatic enzymes almost universally. So pancreatectomy and surgery. This is one that sometimes the patients are certainly not clued in. Even the surgeons are not always clued in. When you have a Whipple procedure for a benign indication like chronic pancreatitis or an IPMN, a cyst that maybe was heading south, you lose not a large part of the pancreas in volume, but you lose a lot of function. The pancreatic head actually has quite a bit of the exocrine power in it, so to speak, about 70% or so. So when a person has a Whipple, they by design, unfortunately, will be missing a large part of their pancreas. And there's other surgeries that people don't think about. Distal pancreatectomy, which happens sometimes with trauma, happens sometimes with small tumors. Patients who have splenic surgery and their pancreas gets caught in the process, or some sort of kind of loss of pancreas in general with like necrotizing pancreatitis. And even as we talk about on the next part of the slide, bowel surgery. If a patient has some sort of bowel resection, gastric bypass, sometimes they're simply not mixing their nutrients in the right place. They're not signaling well to the pancreas. Pancreatic cancer, unfortunately, a not uncommon cause of EPI. I usually tell most of my PCPs, if somebody has either unexplained acute pancreatitis or EPI in someone over the age of 50, particularly someone who has a history of smoking, I would do some sort of imaging test, whether it's a CT, MRI, endoscopic ultrasound, to rule out pancreatic cancer, because you don't want to miss a small tumor that kind of presents itself by sitting on the pancreatic duct, blocking things, and maybe presenting as EPI until the patient's jaundiced, and you usually can't do as much for the cancer. And then type 2 diabetes. Patients with very, very late type diabetes, there is a association with exocrine pancreas insufficiency, and given how common 30 to 35 million patients in the U.S. with type 2 diabetes, this is another population that we sometimes underrecognize. And then the not so common stuff. So acute pancreatitis, as well as its sequelae. So necrotizing pancreatitis, I've seen patients lose large swaths of their pancreas, develop cysts, pseudocysts, which then press on the pancreatic duct and interfere with its function. So there is a controversial amount of literature about using pancreatic enzyme replacement in acute pancreatitis. Some people believe in it, some people don't. I've done it. I've had patients who are just having acute pancreatitis, which is resolving slowly, and they're having terrible diarrhea, they're having abdominal pain and flatulence and bloating, I say, listen, if we put you on pancreatic enzymes for 6 weeks to a couple of months, we're not really going to do you any harm. And there is some literature to support that. Crohn's, as we had mentioned, mimics EPI and is also associated. Celiac disease also associated, most likely from autoimmune destruction and things like that. Type 1 diabetics, especially as they get later in life, partly because they've destroyed their islets of Langerhans, and there's some collateral damage that happens. Gastric bypass. So the average person with a gastrojejunal bypass for weight loss basically has EPI by design. Because of the way they've been rerouted, they miss those signals to their pancreas and to their biliary tree and their liver, because the food's not mixing in their duodenum, it's mixing kind of way down in their jejunum. And yes, there is some pancreatic enzymes that come out, but these are patients who actually are sometimes difficult to diagnose because they can have normal pancreatic elastase, but they're not actually mixing the food with the elastase and with the pancreatic enzymes. And even though you think they have normal function, it's by design they're losing a little bit. So these are patients who, if they've lost too much weight, they're losing too much weight, they're having unexplained symptoms or uncontrollable diarrhea. These are patients you can kind of try pancreatic enzyme. And then bowel resection, if they're missing some of the absorptive part of their jejunum, particularly the ileum less so, it sometimes behooves you to use pancreatic enzymes to kind of really help digest that food. So you give the small bowel as much time as possible in order to absorb everything. So if we kind of break it down, about 37% of EPI is chronic pancreatitis, 35% is that other category, including idiopathic, 24% is cancer, and then this didn't quite make the slide, but that's a 4% is cystic fibrosis. And obviously that is one of the rare ones. So what are the complications? Well, most of it is malnutrition, and most of it is also kind of the vitamin losing, things like that. So coagulation problems because they're malabsorbing vitamin K, cardiovascular events because they're becoming malnourished, obviously reduced quality of life from the various symptoms, osteoporosis, osteomalacia from vitamin D loss, and just kind of general nutrient wasting, muscle wasting, impaired night vision from vitamin A, decreased immune function from vitamin E and vitamin D, and then ataxia peripheral neuropathy because they sometimes waste those water-soluble vitamins as well because they're having so much diarrhea. And ultimately, mortality, obviously a late sign, but, the reduced quality of life really plays into it, and you can help these patients with, some of these therapies. So what are our goals? Well, we want to improve nutrient absorption. We want to reduce long-term complications. We want to make people feel better. We want their GI-related symptoms to go away. And what I tell patients is, okay, we've diagnosed you with EPI. We're going to start you on treatment. So you kind of think about your goals to treat. What are we doing short-term, medium, and long-term? So short-term, we're trying to improve digestion, nutrient absorption. We're trying to fix your symptoms. Interestingly, if a patient truly has EPI and you put them on a proper dose of pancreatic enzymes, they will feel better in days, not weeks, not months, days, because they'll start, absorbing that fat. They won't be losing it, and ultimately they're going to feel better relatively quickly. More medium term is we're preventing those malnutrition associated morbidity and mortality. We're trying to get them back to normal functioning, and then we're trying to support weight gain and prevent long-term complications of that malnutrition and kind of some of the sequelae. So what kind of diagnostic testing we're going to do? So fecal elastase we had talked about. That elastase 1 is a pancreatic specific protease. It survives passage in the stool. A normal level is above 200 micrograms per gram of stool. This is an easy test to order. I have a lab panel that I do for most of the patients when we're looking for other inflammatory things like calprotectin. We're looking for oviparasites, bacterial, viral stuff. I click that box for EPI. It's got me in trouble occasionally because sometimes if you have a profound diarrhea or profound dysentery-like picture from someone having an infection, you can get an EPI-like picture because they're just wasting so much water and electrolytes. Where you can also get yourself in trouble is that moderate. So above 200 to about 500, that's normal because that's about as high as the assay goes, sometimes 600 depending on the lab. Below 100, absolutely, that person almost certainly has EPI in the right clinical context. When it's that 1 to 200 range, it's a bit of a judgment call. If you suspect it, it's usually worth treating. Elastase has a pretty good correlation to pancreatic enzyme levels. This has actually been studied by doing simultaneous sampling of the small intestine as well as the stool, and it is correlative. So my advice is that should really be kind of your mainstay of diagnosis. Imaging. So imaging is mostly for associated conditions and to find stuff we can intervene upon. For example, if someone has chronic pancreatitis and they've blocked their pancreatic duct, we can put a stent in. If they have a large amount of calcifications, they have a lot of pancreatic damage that's starting to impact their life, they could have surgery for that sort of thing. So really, I do recommend for, if it's certainly an older patient who has unexplained EPI, some sort of cross-sectional imaging or an endoscopic ultrasound to examine their pancreas, make sure you're not dealing with an occult malignancy. In young people, I sometimes offer it, particularly MRI, since it's a radiation-free test. Obviously, not the cheapest thing in the world, but if we're really trying to intervene upon it, I've had a few patients where they have either some sort of biliary pathology that's impacting it, or some sort of one girl has a congenital malformation of how her pancreas plugs in her bile duct. She forms these massive stones. It's a bit of a mess. That's obviously an isolated case. So in a young person, I would be less likely to approach doing imaging unless we had other reasons to do so. And I would start with likely a CT scan or MRI. Endoscopic ultrasound, great test. Obviously, the most involved, it is an invasive procedure. They do have to have an endoscopy. The other tests that we have, so that the first one, coefficient of fat absorption, not actually something you should be able to order very easily. This is what's used in every clinical trial. They basically put the patients on 80 or 100 grams of fat, and then they measure how much fat quantitatively is in the stool in 24 hours. And it's a division. It's how much fat did they absorb. It's great as a test. It is impossible to use in clinical practice unless you're doing a really good 24-hour fecal fat collection, which is also available. And that secrene stim test, not widely available, very cumbersome. So really, imaging, fecal elastase, and obviously your clinical judgment is how we're going to be diagnosing this sort of thing. So before we go to treatment, we're going to talk about our patient. This is a 59-year-old male. He is a patient who comes to you with a BMI of about 27.5. His medical history includes he's an active smoker. He smoked a pack per day for the last 40 years. He is a bit of a drinker. He was hospitalized for alcohol use about 5 years ago. He swears he's cutting back, but he's probably not. The patient is currently having abdominal pain in his upper central region of his abdomen, which is radiating to his back. So he's trying to clue you in that he's having some sort of epigastric, perhaps pancreatic type pain. He's had an 8-pound weight loss over the last 5 months because he is self-limiting what he's eating because it hurts when he does. He's complaining of diarrhea, abdominal pain, gas, bloating, foul-smelling stools, perhaps floating stools, and he's been counseled on alcohol smoking cessation. We've told him every time, please stop smoking. You put him on a low-fat, high-protein, high-calorie diet. He saw a nutritionist. It hasn't really made much of a difference in his symptoms. Do some basic blood work. He's anemic. His hemoglobin's 8. He's vitamin D deficient. His vitamin D is 15. Vitamin B12 is okay. And you do an elastase, it's 75. So, the questions we ask ourselves, do we suspect EPI? Well, yes, this is a talk about EPI, but I would certainly suspect this patient has all the cardinal symptoms. He's a drinker, he's a smoker, he has classic symptoms, he has a low fecal elastase, and he likely has maybe even chronic pancreatitis. What underlying diagnosis? That would be the one I would guess. I would hope, he's 57, as we saw, 59, excuse me. And, could he have pancreatic cancer? Absolutely. He deserves cross-sectional imaging, a CT or an MRI. We want to confirm associated diagnosis. We've got our EPI diagnosis already. How are we going to treat this patient? Well, the mainstay of therapy, aside from what we've done for this guy already, which is smoking cessation, alcohol cessation, talk to your nutritionist, is pancreatic enzymes. So pancreatic enzymes are synthetically derived pancreatic juice that's been crystallized and put into a pill. That's what I tell all the patients. It is a combination of amylase, protease, and lipase. It is all put into a kind of a delayed release pill. It is taken with meals, it's taken with snacks, and it helps reduce pancreatic function. It aids in digestion. The important thing to impress upon patients is these need to be taken basically with every meal that has some fat in it and every snack that has some fat in it. If they're eating an apple or a banana, I tell them don't bother. It's probably not, you don't need it. You have other ways of digesting those carbohydrates. Will it help? Absolutely. It's got amylase inside of it, but it's not really super necessary. But with every other meal, you really need to be taking it. If you're not taking your pancreatic enzymes, you're not treating your EPI. And unfortunately, when they ask you, well, how long am I going to be doing this for? I tell them, I don't know. If you feel better, you're going to want to do it. And if you are having, we'll recheck your enzymes. We'll have you check in with us clinically. We'll talk about your symptoms. We might try to get you off of this, but for the foreseeable future, this is going to be what you're using. And I also have this lovely term. I say, when you reach for the salt, reach for your whatever medicine they're going to be on. Basically, that is telling the patients you need to take this right when you start eating. You want these enzymes to hit the stomach at the same time as food. You want them to open up there in a delayed release capsule so they don't get onto your into your mouth, into your esophagus, because they can actually damage your mouth. They can cause a lot of oral irritation if you chew them, for example. And believe me, patients have tried that before. So if you're taking it with your food, that's perfect. You want the food to hit the stomach with the pancreatic enzymes. If you're taking it an hour before, it's gone. If you're taking it half an hour after, believe me, I've heard every single thing. If you're taking it when you first wake up and before bed because you heard you need to take it twice a day, no, really reach for the salt, reach for your medicines. And then the dosing, which we can talk a little bit about, but it varies a little bit. But in general, we're trying to replicate that pancreatic function. Can you replicate full pancreatic function? Absolutely not. If you need to reach, say, 720,000 lipase, which is what the average lipase units per meal that a kind of 160-pound person would produce, you're going to have to take approximately 20 of your average pancreatic enzyme. As much as the companies who make them, I'm sure, would love that, it's impossible. You can't take that many pills, and really, you don't need to. Studies have shown that you need to reach about 10%. So in general, I target, because these things come in dosages that range everywhere from 3,000 lipase units for the little itty bitty babies who have cystic fibrosis, up to 40,000 and 60,000 in some of the formulations for adults. So I usually say, listen, we're going to aim for somewhere around that number, 70,000, 72,000, if it's a 36,000 unit pill. There is a weight-based kind of algorithm to this sort of thing. A person that's below 100 pounds clearly needs less pancreatic enzyme than someone who's above 160 pounds. But I've been surprised. Sometimes patients have variable pancreatic function. So I normally go with 2 with meals, 1 with snacks. That's my standard go. And I tell the patients, you might need 3, you might need 4. We'll have to talk about how we're going to adjust this. And you really want them not to miss any doses. And then you want to adjust. If a patient is doing really well and you want to cut back, both for cost considerations and sometimes they develop not exactly side effects, but a lot of patients tend to get constipated because you've uncovered their IBS-C after you've taken care of their EPI. Sometimes they want to cut back. I'm not a huge advocate of promoting malabsorption in order to help your constipation. I'd rather you took a little bit of Miralax. But there's some patients who simply are like, listen, I get a lot of bloating, cramping, nausea. These are side effects of pancreatic enzyme replacement. And I say, okay, let's try to find a minimal amount that you can use. And then maybe, you can also stretch your supply a little bit. There are 5 different brands available in the US. I think they are basically interchangeable except for Viacase, which is the last one. Creon, Zenpep, Pancreas, and Pertine. They are essentially synthetically derived. They have these pig pancreases in a lab that are just cranking out enzymes. They're crystallizing it, they're encapsulating it. Their dosages are all essentially the same. There's a 36,000 unit Creon, there's a 40,000 unit Zenpep, there's a 37,000 Pancreas, and I believe a 38,000 Pertise. To me, that's all about the same. They come in lower, they come in higher, but when you go for the big business dose, that's kind of the one you want. Viacase is a little bit different. I use this very sparingly because it actually is an uncoated one. It can also come as a powder, and it feeds back on the pancreas. So if you have someone who has severe chronic pancreatitis who has a lot of pain, and I'm actually trying to make their pancreas do less, that's when I would choose Viacase. It's a little bit variable in efficacy, but that is the difference between that particular enzyme. So what else do we need to do? Well, lifestyle modifications are sometimes key. You need to optimize, not so much adjust, but optimize dietary fat. I tell patients, you've been restricting fat. Let's choose some healthy fats, polyunsaturated things like that. Let's start adding them back to help both your nutrition and also see how well you're doing with this medicine. Nutrition counseling, I do send folks to nutritionists routinely because sometimes it can be very helpful to get a third party involved to kind of look at what the patients are actually eating. Sometimes they're more honest with them than they are with you because they want to tell you what you want to hear, that sort of thing. Discontinue alcohol as much as possible and quit smoking. I harp on the smoking thing every single time. Smoking is bad for the pancreas, it's bad for the colon, it's bad for the bladder, it's bad for your lungs, obviously. So, and you're trying to minimize their further pancreatic damage. Vitamin supplements. So you can check vitamin levels, A, D, E, and K. I'll tell you from experience, I don't really check vitamin E because I'm not sure vitamin E does super much in the body, and they can easily take supplements. Vitamin K, mostly synthesized in the liver, so unless they have cirrhosis, it's not a huge issue. Vitamin D, absolutely. Even here in sunny Florida, everyone's got vitamin D deficiency. I'd say probably 2/3 of the patients that I see. So consider supplementations, check those vitamin levels, vitamin A, vitamin D, most importantly. And then alternative products. So I have patients who come who, for whatever reason, do not want to take their pancreatic enzymes. Cost is an issue. Pill burden is an issue. They don't like medicines. They don't like pharma. I don't know, whatever it is. they want to know, are there natural products that I can use? Well, the short answer is not really. There are vegetable-derived enzymes that come from pineapple and papaya and things like that, bromelain being the one that's most well known, that can help. I've had a patient or two who has taken dietary supplements that include some of the stuff. Most of it has claims to have about a 4,000 to 6,000 lipase unit activity. Maybe not, because we have to take that stuff at the label face value. I'm definitely an advocate of dietary supplements and complete nutrition and things like that, but the kind of natural, quote unquote, natural alternatives to pancreatic enzymes, not the best product. Now, if they want to use something to promote their IBS, licorice root extract, various other peppermint oil, things like that, absolutely. That's been shown for decades, centuries to be a treatment. But ultimately, as a substitute for pancreatic enzyme, I don't think there's really a one-to-one supplement that's available. Dose adjustment. So you really want to follow up with these patients. I usually want to see most of them back in 4 to 6 weeks. Not always feasible, but at least a telehealth check-in or perhaps even a portal message saying, hey, I'm doing great. I'm doing so well, or I'm doing okay, 80% of the way there, but maybe we need to adjust the dose. And you need to titrate that dose. Some patients weigh more, how much fat they're eating, how much steatorrhea they started with, which is really, how much pancreatic function they have, how well do they respond. And then you're really balancing pill burden with underdosing and skipping doses. If they're trying to stretch their supply for financial reasons, which unfortunately is something we see a lot with these medicines because they tend to be both brand name and expensive, great. But I tell patients, listen, we really don't want to be, we're trying to optimize things. We'll try to adjust this as best as possible. I don't want you choosing malabsorption over the fact that you need to stretch these pills. And then there's a lot of, patient assistance programs and things like that. And then treat new symptoms. The most common thing, as I said, constipation. They're going to say, well, now I'm constipated. What do I do? Well, I take some laxatives. Let's adjust your diet. Let's add fiber, things like that. And then coexisting conditions, obviously that chronic pancreatitis comes in and celiac, things like that. Obviously, if there is something you can intervene upon or the GI doctor can intervene upon, they should. So side effects real fast as we wrap up here. Pork allergy. So as I said, these are made from pig pancreases. I haven't discovered anyone with a pork allergy bad enough that they can't take pancreatic enzyme, but it does exist theoretically. You need to be careful with patients who have hyperuricemia and gout because there's a lot of purines and things like that in here. Renal impairment as well, although you can use it in patients who are on dialysis. You just have to be a little bit careful. Fibrosing colonopathy, which you'll see on the package insert. This is absolutely impossible in adults. It is seen in children. You need to take something like 2,500 lipase units per kilogram per day in order to achieve a risk of fibrosing colonopathy, which is kind of a damage to your colon. It's simply impossible in an adult who even weighs 100 pounds. They'd be taking like dozens and dozens of pills a day. You don't want to crush, chew, suck on, open, alter. I've heard every single thing. This stuff can irritate the oral mucosa. Don't put it in applesauce. Don't chew on it. Don't suck on it. Don't do any of that stuff. The only exception to that is if you have a patient with a G tube or a J tube who needs this stuff, you can open it up. You can kind of dissolve it in a little bit of liquid or put it in with their tube feeds, and it's not a bad substitute. It loses a little bit of that delayed release, but if they can't take pills, they can't take pills at that point. Potential viral transmission. This only became a big problem, obviously, in the last few years. Theoretically, this isn't a human product, but it is an animal product. Could there be viral transmission? Yes, it's never been documented, but it is something to think about. And the most common side effects are that vomiting, cough, and nasopharyngitis seen in studies, headache, bowel habit changes, flatulence, things like that. And then the cost. These are unfortunately not cheap medicines. Most of the companies have some mechanism to help the patients out. I've done samples, I've done foundation stuff. We have some specialty pharmacies that specialize in kind of getting all the stuff together for the patients. There are financial-based patient assistance programs. So sometimes it just takes a little bit of digging to find exactly what's available. And I tell my patients, I'm not married to a brand. Whatever will be the most cost-effective and most effective for you, that's the one we're going to use. So last thing, our last patient, a little bit of a different patient. This is a 41-year-old male who had gastric bypass. He had full Roux-en-Y gastrojejunectomy. He lost a ton of weight, 120 pounds. He went from a BMI of 51 to a BMI of 34 by design. He's 6 years post-bariatric surgery. He still wants to lose some weight, but he's having a lot of symptoms. He's got loose bowel movements with each meal. They're worse when he eats a lot. He's had fatigue, which he can't really recover from. He's not having nocturnal bowel movements, but he's having bloating that he gets after eating, and then it's continuing throughout defecation. He still has the obesity. He's got mild hyperlipidemia. He has fatty liver, so he still could use some more weight. And he had diabetes that's gone away with the weight loss. So what are we going to do for him? Well, he's seen a nutritionist already. He's had one plugged in for years. We tried an elimination diet. We took out lactose. We took out gluten. We took out everything. It didn't really help. And so we even treated him for SIBO. We put him on some meds. We put him on different antibiotics. We tried various restrictive things. Didn't really work. So what do we want to do for him? Well, we did some blood work. He's anemic. Hemoglobin is 11.2. Vitamin D is low. B12 is normal. His iron is a little bit low, but that's, and his ferritin is 4. And that's a little bit has to do with his gastric bypass and probably a little bit to do with his presumed EPI. And then he's got an elastase of 91. So what are we going to do? Well, this is a patient that I would start, even though I can't 100% prove that he's got EPI. He's a little bit borderline. We've ruled out everything else. I would start a treatment for this patient. I would start him on a reasonable dose, maybe even a higher dose because he's a larger patient. And he, by design, is going to be malabsorbing things he's already not using, let's say, a third to half of his small bowel. What supplements are going to use? Well, he needs vitamin D. He needs iron, which is beside the point, not really so effective. I'll probably start him on a multivitamin to get that A and E in there as well. And then I would say he needs to perhaps be looking at nutritional supplements, things like that, perhaps substituting different things that kind of help with high protein, things like that. And any other diagnostic testing in this guy, I probably wouldn't go crazy. He's 41. He has a reason to. He's not really a setup for chronic pancreatitis. If he hasn't had a CAT scan or an MRI or some sort of even small bowel evaluation to make sure he doesn't have an internal hernia or something crazy like that, reasonable. But I think I would be comfortable with this patient just going on treatment and following him clinically.